Good morning, everyone. A few housekeeping notes to start us off. We'll be live streaming on YouTube today. Last night's feed has over 150,000 views so far. So to keep that energy going, we would like everybody to move towards the front of the room and fill up these front seats so that people coming in late
Let me see. We should, okay. Good morning, everyone. So our first panel of the day is about the important issue of that we started to cover last night, and that's about our climate. But these people, these leaders that you're going to hear from today, have been taking on big oil and big gas for quite some time, and that's what we need to be doing. It's one thing to analyze the issue and to learn about the data, and then think about all the different science that we can do in a positive way, but there is a time that we need to finally take on big oil. So it's my pleasure to introduce people who are doing just that. Joe Gevarghese from Our Revolution, Eric Pica from Friends of the Earth, Jamie Minden, from This Is Zero Hour, and Reverend Lennox Yearwood from Hip Hop Caucus. Please welcome them to the stage.
Thank you. Good morning, everyone. Good morning, everyone.
Morning.
All right. Welcome to our panel discussion on taking out big oil by taking on fossil fuel subsidies. My name is Joseph Givargis. I'm the executive director of Our Revolution, and I'm going to both participate in the panel and help moderate it. Before we begin, I want to quickly set the table for this conversation. We heard from Ben Jealous and Bill McKibben last night, right? We understand that the climate catastrophe is upon us right now. We see it. Some of us experience it. We know that we have a limited time to act before it gets much, much worse. And the fundamental question for us is, what is to be done that can be impactful given the scale and complexity of the challenge that confronts us? You know, and I would say this, right now we're fixated on the outcome of the 2024 election, and we should be, given that our democracy is on the line. But so too is the fate of our planet. And so the conversation we're going to have today, what is to be done, is timely. And I would argue it's timely because Donald Trump is pitching a deal to big oil executives, right? Give me $1 billion in campaign contributions, and I'm going to make sure the United States government keeps the fossil fuel industry in operation. I'm going to bless and finance the fossil fuel industry using the power of the United States government. What this quid pro quo, I think, ultimately reveals is just a weakness. And the weakness is this: just how dependent big oil is on the largesse of the United States government. That's what the exchange reveals for us. And the truth is, as taxpayers, we, the people, give big oil hundreds of billions of dollars every year through lucrative tax breaks, through contracts, through loans, through licenses, through leases. We fund their business model of death and destruction. Bernie recently introduced the End Polluter Welfare Act to phase out these lucrative tax subsidies, to cut back on the corporate handouts to big oil that are doing us in. And that's an important step. The thing is, we need a movement and a strategic opportunity to be able to get that policy over the finish line. We know that going into 2025, big oil has a plan, right, to keep the taxpayer-funded money pipeline going. They are making a plan right now. The question for us as progressives, as a movement, is what are we going to do to turn it off? We're fortunate to have an awesome panel of three of the leading climate campaigners in our country who are going to help us discuss this question and lay out strategic opportunities where we can make an impact, a transformative impact. First, we've got Eric Pica. He's the president of Friends of the Earth, which is, I think everyone knows, a leading environmental organization that has been on the front lines of the fight to end fossil fuel subsidies. We've got Reverend Lennox Yearwood. He is the president and CEO of the Hip Hop Caucus. Reverend Yearwood has also been on the front lines advocating for climate justice and civil rights and making sure that marginalized communities have their voices heard as we try to fight for climate justice. And lastly, we have Jamie Minden from 0 Hour. 0 Hour is a youth-led movement that's dedicated to addressing the climate crisis. And she represents really the next generation of determined voices who are speaking up to demand change now. People like Jamie are going to inherit our common home. So I'm going to kick off with a question for Jamie, and then we'll move along to the panelists. Want to make sure that we also leave time at the end to engage you for questions and comments. So without further ado, Jamie, let's get started. Tell us a little bit about how young people who are on the front lines are viewing the state of the climate movement right now. Are we winning or losing the future? And what do you guys think needs to be done?
Yeah, absolutely. I think an important note to make is that we're not just viewing the state of climate, we're experiencing it. I'm 21 years old, and I've never lived a year of my life without experiencing extreme climate disaster firsthand. I was born in the Bay Area, California, where pretty extreme drought started right before I was born. By the time I got to high school, we didn't have snow days, we had smoke days, where it was unsafe to go outside because the wildfire smoke was too thick. By the time I got to college, we simultaneously were experiencing extreme flooding and drought. And unfortunately, my story is not a unique one. We have an entire generation of young people growing up this way. Like, this is not only our future, this is our present. We heard last night about what's going on in New Delhi right now with 126 degrees Fahrenheit, causing mounting deaths, water shortages and wildfires. The beginning of this month in Brazil, hundreds of towns and Rio Grande do Sul were underwater. Mexico City, a city of 22 million people, could be without water in a matter of weeks. And so this is not just the future, this is the present. In April, the head of the UN Climate Agency said that we have just 2 years left to make drastic changes to the way that we spew greenhouse gases into our atmosphere. And as we know, the science says that global emissions must be halved in the next 5 years in order for us to have a chance at a livable future. And so we've had, as a climate movement, some really good clean energy wins recently. There's, as speakers were saying last night, it's important to celebrate the wins. But it's also important to note that the fossil fuel industry has not been stopped in any meaningful way. In fact, they have only ambitions of growing. Our country is at the core of the climate crisis. We produce more oil right now than any country ever has in the history of this planet. And this has given ExxonMobil and Chevron their biggest yearly profits in a decade. The climate movement, especially the youth movement, but in general, we're scattered. We've always had to be on the defensive. We've always had to be reactionary. And we've never been able to reunite around a single fight. And there's a good reason for this. There's so much work to do. I'm not trying to blame people, but we've never been able to be on the offensive. And unfortunately, we don't have much time. We have 2 years left to meaningfully turn this around and 5 years left to completely halve our emissions. And so now is the time to go for the jugular. Now is the time to kill the fossil fuel industry because we don't have another chance at survival after this. And so I think that fossil fuel subsidies are a really key conversation to be having right now. Ultimately, to answer your question, it's up to us whether we win or lose the future. I think that it's a coin toss right now, unfortunately. But in order to win, we need to go on the offensive because defense has not been working.
Thanks, Jamie. So I want to pivot to Eric. As Jamie said, we need to go for big oil's jugular. Bernie's always said billionaires shouldn't exist. That's right. I don't think big oil should exist. And so, Eric, the question is, as you look out at the future, right, what are the opportunities that we have as a movement to take out big oil and to impact their bottom line?
Yeah, well, thank you, Joseph, and thank you for this great event. We're going to have what's called the Tax Super Bowl in January of 2025. And what that is all the Trump tax cuts that were passed in 2017, particularly the ones that impact individuals, are going to come up for reauthorization in Congress. We have an opportunity. We know that there will be a tax bill that if it is not passed, will end up increasing taxes on all individual Americans. And so we have an opportunity for 18 months to organize, to take out the oil and gas industry. Because this tax bill will have to be reauthorized, and it will have to be paid for. And the big fight will be over corporate taxes and the extension. And so when we talk about the oil and gas industry, what are we talking about? We're talking about over $110 billion in tax breaks over the next 10 years. When we talk about the oil and gas industry and the tax code, we're talking about, who knows when the tax code was first authorized and created? 1913. You know when the first oil and gas tax break was created? 1913. So we have a tax code that, since its creation, was subsidizing the oil and gas industry. Since its creation, the tax breaks that Ben Jealous and Bill McKibben were talking about last night, the Inflation Reduction Act tax credits, we have to get those reauthorized in 10 years. So the renewable energy is going to be like, help us, Congress, to get these tax breaks in 10 years. Oil and gas has had these tax breaks for over 100 years in the code. And this is the important thing. We have a moment. We have 18 months to organize. The environmental movement, the progressive movement, has never organized on oil and gas tax breaks at the scale that is possible right now, because we have a target date. We have January 25. We have 18 months. And we know that these tax credits are valuable. The oil and gas tax breaks increase the profit margins of these industries to 50, 60% on their investments. There are investments that the oil and gas industry make as a result of these tax credits that they would not do if they were competing on a regular market. This tax fight can be a national tax fight. This tax fight can be a state tax fight. There are states around the country that subsidize the oil and gas industry on top of what's going on federally, right? So we can use this moment to galvanize a climate movement against the fossil fuel industry to go after their bread and butter, which is the oil and gas tax rate. And not only that, internationally, there are between $800 billion and $1 trillion annually going to the oil and gas industry. There are campaigns in Europe right now to repeal oil and gas tax breaks and subsidies. They are looking at the United States and what the U.S. is doing in our own subsidization of the industry. And if we can launch this movement over the next 18 months to repeal these tax breaks, what we can do is we can galvanize state-level fights, and we can help encourage the international fights. And I think we can win. I think we can win this fight if we take it on, and if we win this fight, we go after the money that's corrupting the politics. They're spending hundreds of millions of dollars in campaign contributions and lobbying. We can go after the money that's eroding. They're funding politicians that are eroding everything that we care about. So if anything else, taking out the oil and gas industry and their subsidies takes out the very opponents that are fighting against everything that we care about. So that's the opportunity we have. 2025 Trump tax cut reauthorization, 18 months between now and then to organize a movement to take them out.
Yeah.
Thank you, Eric. So Jamie laid out the urgency of now, right? We've got a limited window to act. Eric gave us the opportunity, right? We know that there's going to be a serious negotiation and campaign around the expiration of the Trump tax cuts in 2025. Our goal, and my question for Reverend Yearwood, is how do we make this issue, how do we put big oil at the center of this fight around taxes?
Well, let me Thank you for that question. And it's really great to be here with you. I really am excited to be part of anything that the Sanders Institute and obviously Bernie Sanders is doing. Definitely, it's so important now to have true progressives and leaders in any form of government, but particularly in Washington, D.C. It's an honor to be in a place here with my esteemed panelists. We're doing some great work. And one of the greatest organizations to do this work, their president, CEO, Ben Jealous, with the Sierra Club. Just a little bit of background so you can hear where I'm coming from on this issue. I wear a lot of hats, literally. And yeah, and so I would say that the three hats that I get to wear is doer, donor, and door opener. And so you heard the doer hat. President and CEO, Hip Hop Caucus, good to see Josh Fox here. They do a lot of work around storytelling and production, creating content to help people to understand the movement. So really proud of Hip Hop Caucus and what they're doing in that arena. As a door opener, as somebody who's a product of the civil rights movement, was mentored by Dr. Dorothy Irene Height. I am in a position where I want to open doors for new generations, and particularly what I believe is a solution, a climate movement that is led and run, that is a matriarchal, black woman, queer, young people, frontline, fence line, environmental justice movement. I actually think that is the solution to winning on climate. So my job is to open up the doors to many people who you don't know. And then my other hat, I think is actually very important for this conversation, is that I am the senior climate advisor for Bloomberg Philanthropies, which part of my job is to literally figure out how to give out over $1 billion to help win on this issue over a period of time. So you can see I have a very extensive standpoint. The key thing here is that what I can tell you is that the climate crisis is real. Being from Louisiana, born in Shreveport, being from a place that's called Cancer Alley, which is an 85-mile stretch of land between Baton Rouge and New Orleans, because of petrochemical facilities that kills Americans. The climate crisis is real. And Jamie said quite well, Americans, not just black Americans, or brown Americans, or indigenous Americans, or poor, or rich, white, straight or gay. Americans are dying because of the climate crisis and because we are addicted to fossil fuels. More so than that, which is almost like a cruel joke, we are paying those to kill us. Their business plan literally means a death sentence for our communities. And we give them our tax dollars, not to our schools, not to the playgrounds, not to helping create sidewalks safer for our community. We've been giving tax dollars for these folks to not only be greedy, but to then eliminate Americans. So the fundamental part of this conversation is that do we, as Americans, want to fund something that not only is killing us now, but will destroy our future later? That's what we're talking about. That is not a Democrat issue, or Republican issue, or independent issue. That is just a human issue. That do we feel okay with giving someone money knowing that it is killing us? So the core thing here that I would want to dig into with my years of being in this movement really center around the fact that our movement needs a lot of work to be done. We, as a climate movement, are unfortunately at this time a siloed, segregated, progressive climate movement, meaning that we have a tendency to silo our issues depending on where we are. Very important issues. It could be Atlantic Coast Pipeline, the Mountain Valley Pipeline, Line 6, Line 3, LNG. It could be offshore wind, it could be renewable energies, it could be climate finance. It could be a myriad of things that we're talking about. But unfortunately, we do that in silos. And we also do it making us put people into buckets that we feel fit us. So for instance, we will put people that, if you're black, that means you're, or brown, it means you're environmental justice, you're front line, you're fence line. If you're from Vermont, then we're climate activists working on these issues. If you're from the Bay or you're from Detroit, we put ourselves into these buckets. Where that gets shattered and where it got shattered was last year. Is when the hauling of vinyl chloride, which is a petrochemical, from Houston was traveled through Norfolk Southern on a railroad, brought throughout the country, and then exploded in East Palestine, Ohio, causing that community, predominantly white, predominantly moderate, mostly Republican, to be then a frontline, fence line community. What that also exposed was two things. Because it was a primarily white community that now was suffering with something called environmental justice issue, our movement literally did not show up. And in that process, who did show up, so much talk about the person who was running for office, let's talk about him. A month after the accident, Donald Trump literally became the first person to launch a presidential campaign from an environmental justice site when he went to East Palestine, Ohio. Now, of course, it was disgusting. He was throwing out MAGA hats instead of anything else, like paper towels did in Puerto Rico. But regardless of that, that is where he launched his campaign from. And it was strategic because the mere key of his campaign was that this country, this administration, does not care about white people. And so he launched it there at an environmental justice site. With the script, I am very happy this administration has done the IRA, they've done BIF, they've done all kinds of legislation. They paused in LNG, phenomenal things, but did not show up. President Biden did not show up to East Palestine until 1 month after the 1-year anniversary of that derailment. And so the thing here is that our movement, which is decreasing, the Pew Research did a study saying that in 1989, 78% of Americans, Republican, Democrat, Independents, consider themselves to be environmentalists. In 2022, that number has gone down to 38%. So that means that people no longer see themselves as environmentalists anymore. They do not see, now the issue of clean air and clean water is still very high, particularly the issue of plastic, which is something we should talk about, that people across all lanes hate plastic. But this is the key thing here. The issue on taxation allows us to once again broaden our movement. It allows us to go to Republicans, to go to Democrats, to go to independents, and go across this country. Go to my folks, I'm a former Air Force officer, go to folks in the military, go to folks in different parts of the world in this process, and go to them and says simply, your tax dollars are going to go to those who are rich and are killing our communities. Do you want that? Is that what you, Republican, Democrat, Independent, are signing up for? Because how you feel about the climate crisis, are you okay with that? And if you're not, then we should do everything we can as Americans, not progressives, not climate activists, not folks in Vermont, not folks in California, not folks from Louisiana, but as Americans, can we stop that madness? Because the reason why oil and gas is cheap is because we are already paying for it. That is the reality. So I leave you with this in this process as we move forward in this conversation, that our movement has a lot of work to do. I mentioned to you that I'm also on the funding side in my work. The New School did a study in which, in that study, $1 billion, which was given out, actually $1.3 billion, which was given out for climate advocacy to fight on this issue. Out of that $1.3 billion, only 1.3% went to BIPOC and environmental justice-led organizations. Meaning that while we call for Justice 40 on the federal level, we don't even have that within our own movement, which means that we don't view that as important. So I do think that we need to do a number of things as a climate movement. Yes, we can talk about what's going on in New Delhi. I think my dear brother Bill mentioned that last night. I think we should talk about all of that. But we don't need to go into the oppression Olympics or into trauma porn to convince people that their tax dollars should not be used to eliminate us as a human species on this planet. We simply need to go to them and say there are better ways to use our money than for paying for folks to have a yacht in the Atlantic or the Pacific Ocean, which unfortunately is all coming together. Thank you.
Woo. Thank you, Rev. The challenge here, I think there's an incredible amount of opportunities, right? There is a legislative opportunity that's coming up. There's a messaging frame around the use of our taxpayer dollars to fund our own deaths and destruction. Those are all, I think, pretty significant. The truth is, though, right, we face challenges depending on who wins power next year, whether it's a White House or different houses of Congress. So how do you guys feel this plays out under those scenarios? Is this a trifecta only campaign, meaning Democrats control all branches of government, or is this something that extends beyond that?
Go ahead.
I think we have to wage the fight regardless. I mean, the oil and gas industry has been operating with impunity for over 100 years. They're corrupting our politics, they are polluting the climate, and they're getting away with it. We've discovered during the Inflation Reduction Act fight, when there was a real effort to repeal the oil and gas subsidies, that they expended a lot of political capital to keep those subsidies in place. And so regardless, Joseph, of the political outcome, the fact that we can wage a campaign that forces the oil and gas industry to expend political capital to maintain their largesse from the federal government, regardless if we win or we lose, is a winning strategy for us. Because that means they're not trying to repeal the stuff in the Inflation Reduction Act. That means that they're not trying to work on reducing their corporate tax their corporate taxes in other means, in other areas, right? It means that they are not kind of focusing on like how to further game the system than what they are. So if we can put them on the defense, regardless if it is a trifecta or some sort of split government, the fact that they have to go to Congress and justify their $100+ billion in tax breaks means that they are spending political capital that is of value to them. And to the extent that we can force them to spend it and utilize it to justify what they're doing, because it's unjustifiable, as the Rev said, we're winning that fight.
Go ahead. Well, I think, one, they want more money. Let's be very clear. This is not, they're not.
More money.
They actually, this is what they're looking to get out of these tax subsidies and tax breaks. They actually want more, and so they're looking forward to that. And obviously, we've heard the now infamous story of them wanting to pony up, or be asked to pony up $1 billion, which is like a discount for what they're looking to get. I do think this is the thing that's important about this. I think narrative storytelling and narrative is critical in this conversation. We have to, I think sometimes we preach to the choir. I know Rev here from Burlington knows what I'm talking about when I say that. But we preach to the choir a lot, which means that we forget that people don't know this, what we're talking about. They don't understand. So you may not understand some of the pieces around that, the need that these tax breaks are coming up, the needs for that there's still ways to stop these things. I think that we have a situation here where, and let me be very, very clear, the fossil fuel industry is evil. I mean evil. We have never as humans, dealt with anything as global and as destructive and as suicidal as this industry. It used to be a time where people were extractive and they would hurt other people, but now we're at a time where this industry is literally willing to sacrifice their own children and their own children. They know the science. They're willing to have their own children live horrible deaths. And when you're dealing with someone who is understanding that their own kids are going to have a horrible existence because of their greed and they still pumping, you're dealing with a different kind of entity. You're not dealing with something that is actually you can reason with or you can kind of just bargain with. This is something that is literally so evil. They are putting plants on former plantation sites throughout the South. Like they're literally going down and seeing where black people were enslaved, beaten, and raped, and that is where they are now putting their plants. This is an entity that clearly looks at zoning, knowing that 68% of black and brown people are now living within 30 miles of coal-fired power plants, but they're sitting around boardrooms and designing that. Like, this is not the entity. This is something who I actually was at the last COP conference in Dubai, and Darren Woods was there, who's the CEO of Exxon. And I didn't really want to talk to Darren Woods, the CEO of Exxon. And I was trying to make a beeline. I saw him looking at me. I was trying to make a beeline to the bathroom, but he cut me off. He was pretty fast over there at Exxon. And so, and then he was like, wanted to tell me how I was wrong on the campaign we have on stopping petrochemicals, wrong on that. And I said, all right, I guess we're going to have this talk right now. We having this conversation? I said, all right. I didn't know we have it in Dubai and at the climate conference. But this is the thing that got me. I told him, I said, well, listen, Exxon has lied. You have done so much destruction. Thank God Vermont is now going to hopefully has a law to hope you'll get some of that money back, what they've done to you here in Vermont, and other states take your lead. But this is what he looked me back in the eye. And I told him, I said, what you're doing is killing our people. And he looked me in the eye and says, no, it's not. No, it's not. And me knowing that I live in a community called Cancer Alley, that people are dying, and you look me dead in my eye, means that you are okay with us dying. So when I say this, we have to use every measure to take away not only their social license, one, two, we have to take away their funding. We must stop the money pipeline at all costs. Our banks, our funding institutions, nothing can fuel our destruction. And three, we must work with groups like from the Hip Hop Caucus to Sierra Club to LCV to Friends of the Earth and many others, and we have to rethink our climate movement, our revolution. We have to rethink our climate movement. We really do. Because I think that we have limited ourselves and we're shrinking because we are not broad enough to include everybody in this new clean air, clean water revolution. And I think that we have siloed ourselves and we must stop that. So those are the three things that we need to leave out of this thing with. And if we do those three things, this is the thing. We don't get any cookie bin or we don't get any awards or ribbons for that. And most of us, in reality, except for maybe you, I told you this earlier, may not even be around to see if we win or lose. But like for me, as I sit on the stage in Vermont, in this state that was the first state to get rid of slavery, for me as a black man, I see the benefit of Frederick Douglass and Harriet Tubman and many others unnamed. I pray that we can stop this madness of funding people who are killing us through taxation, that I won't see and you won't see 100 years from now what it looks like. But if they have clean air and clean water and they live decent lives. And our children don't hate us to the core of our being because we were more worried about a felon or other policies than about making sure that we transition from fossil fuels to clean energy. And I'm telling you, that's all that's going to matter. Even for the oil execs, like the Rockefellers, who now said they had wished they had been a part of the Beyond Coal campaign. Their descendants will curse them. It will happen. But unfortunately, if we don't have clean air or clean water, it won't matter. That is what this fight is all about. That is a stake we're leaving for future generations. That they simply can live. Thank you.
So I think we're running out of time. Okay, go ahead.
Oh, I'm sorry.
Yep.
I just want to say, I think, you know, this is also an opportunity to sweep the legs out from underneath the fossil fuel industry.
Yep.
As you said, Rev, I mean, 100 years from now really matters, but also what's going on today and within the next 5 years really matters.
Yep.
I think within the next 5 years, I mean, our world is going to be pretty unrecognizable in many ways. Whether you're here working in healthcare or income inequality or labor, the reality is that this issue is about to become a part of your work if it's not already. Climate's not just an issue for environmentalists. I mean, it never was, but really now it's about to not be. And so I know we all have our own fights. I know everyone here is working on things that are really, really important. But if we don't all go out on this fight, if we don't all go out on climate, we're going to get taken out. I mean, it's a matter of survival. And so, yeah, that's all I wanted to say.
No, that's right. And I want to do an amen there. Because at the end of the day, it is either us or them. It's either we the people or it's big oil. That is the choice. And we have to do everything in our power to take out this industry. They should not exist. So last question, and we'll keep it brief because I think we have to pivot to the next panel, is what comes next? What can people in this room do to plug in to the conversations that we're starting to have?
I think the first one is we've got Senator Sanders introduce the End Polluter Welfare Act. It is the most comprehensive bill out there to eliminate every oil and gas fossil fuel subsidy that is in the tax code, that is in the leasing, that's in the loans, that's in the royalties, it's in the giveaway. I mean, every group, every leader here who hasn't should be signing on and endorsing the End Polluter Welfare Act, because that is the organizing vehicle. We've got to get support behind it. We've got to get members of Congress on it. We've got to get community activists out there in the streets talking to their members and say, this is what we got to do. Because that becomes the base for this fight that we need to have in 2025 when the Trump tax cuts come up for reauthorization. So that's step one, and like one of the more important steps we can take right now.
Sounds like a good first step. All right, I want to thank our panelists. I want to thank Jane and David for having us. Look forward to continuing this conversation. Thank you.
We're going to be moving to the auditorium for the next panel, and that'll start at about 10:05. Take a picture. Welcome back, everybody. Welcome back. Could you please take your seats? Thank you. So we've got a lot of directions recently that are actually very actionable steps as opposed to this is the big picture. We've got the big picture, but we've also got actionable steps. And so the climate discussions have been a real call to action. We look forward to moving it forward and continuing our collaboration. The same needs to be said about healthcare, that we need actionable steps, real solutions. And our next speaker, Dr. Carolyn Missouri, is coming from Washington. She is the chair of the White House Women's Health Care Initiative, and is going to be telling you about some research that's going on. It's a very exciting time in terms of women's health care research. So Dr. Carolyn Missouri, please welcome her. Thank you.
So my thanks, first of all, to you, Jane, for inviting me today into the Sanders Institute. Can everybody hear me adequately in the back? Yes? Okay, great. Thank you. And I very much appreciate the warm welcome that I've received since I've been here. Today, I'd like to provide a brief snapshot of just some of the substance and the actions of the initiative that President Biden launched on November 13th, 2023. And the screen's coming down, so I'm going to pause for just 1 second. There, great, thank you. I'm not going to show you anything on the screen. I'm just going to talk with you. So the President launched this on November 13th, 2023. It's led by the First Lady, Dr. Jill Biden. We work in collaboration with the White House Gender Policy Council, and I am very honored to be the chair of the initiative. The goal of the initiative is to fundamentally change how we approach and fund women's health research. And this is because, for far too long, women's health has been understudied and women's health research has been underfunded. It was only in the 1990s that the prevailing scientific tradition of generally excluding women from clinical trials as participants began to change. This change was based on the increased recognition that research conducted solely on men could not necessarily be applied to women. And as a result of excluding women, we were faced with a very significant knowledge gap in information for caring for women. Moreover, in the last 2 decades, we've had serious progress, no question. However, we still know too little about how to effectively prevent, diagnose, and treat a wide range of health conditions in women, leaving women and their healthcare providers without the tools that we all need to respond to conditions that, first of all, affect women uniquely. For example, endometriosis, especially impacting young women, fibroids, more common in Black women, preeclampsia, a cause of our country's high rate of maternal mortality, and debilitating symptoms of menopause that many women experience and lead to absence from work and inability to care for themselves properly. Conditions that affect women secondarily differently than men, so they may occur in both women and men, but they affect women differently, such as those found in heart disease, the greatest cause of mortality for women in our nation, and in complex and wide-ranging brain-based disorders such as epilepsy, stroke, multiple sclerosis, and many others. And thirdly, conditions that affect women disproportionately, ranging from Alzheimer's disease. 2/3 of the individuals who suffer from Alzheimer's disease in the United States are women, to migraine, to depression, one of the greatest causes of disability in women worldwide as well as nationally, and the wide array of autoimmune disorders that occur, whether we're talking about rheumatoid arthritis or thyroid disease. 80% of all autoimmune disorders occur in women. There's also the issue of chronic conditions, conditions that endure over a lifetime or long periods of time. These are more common in women. And multiple disorders occurring at the same time, also more common in women. And although we know that women tend to live longer than men, the estimates are that 20% more time is spent in poor health for women than men in our nation. So to pioneer the next generation of discoveries that will close these significant research gaps, the President, through the presidential memorandum that I mentioned he signed in November, first asked how can existing federal dollars work harder for women, and directed each member of the initiative, which includes the Department of Health and Human Services and all its multiple components, such as, most notably, the National Institutes of Health, but many others, Departments of Defense, Veterans Affairs, Agriculture, the Environmental Protection Agency, and the National Science Foundation. These are the members of the initiative. And he has asked these members to provide, as Jane would say, actionable recommendations for how they'll advance women's health research through policy and programmatic changes. As these agencies begin work on their recommendations, which they have done, and I'll return to this to tell you some of the outcomes, we began listening sessions, roundtables, and discussions to understand the health focus and concerns of many different stakeholders, including those seeking care, healthcare providers, advocacy groups, foundations, professional societies, and others from public and private sectors. And I would say that perhaps because of my own personal training, these really were listening sessions. We wanted to know what people thought was needed, what was absent, and what needed to be provided. And throughout all these experiences and discussions, we listened for opportunities for change. And among recurring themes, we heard about several major issues. First, the importance of recognizing differences among women and dealing with health disparities, including in clinical trial participation and retention in those trials, because that is a major factor as well. Increasing interdisciplinary collaborations that allow researchers to address complex health problems. We often work in science in more siloed ways, and we hear that across other areas that people are working on here today. And we recognize that in order to deal with that, we have to work together in science and address those health questions that are complex and can only be answered if multiple disciplines work together. For example, how is immune system dysfunction a common link across multiple disorders? Or how does a primary brain disorder, such as stroke, relate to other vascular disorders, such as preeclampsia and heart disease? Dr. Biden also heard that, despite advances that could provide women with improved care, it takes too long to translate research findings into the marketplace. Recognizing the value of this last recurring theme, and that we need to do more and move faster so that women see the results in their health and in their lives, 100 days from the signing of the presidential memorandum in February of this year, the First Lady announced ARPA-H's first ever Sprint for Women's Health and their commitment out of their budget of $100 million dedicated to transformative research and development in women's health. This new sprint, under the leadership of ARPA-H, which is part of DHHS, and it's the initial stand for Advanced Research Projects Agency for Health within HHS. Now you know why it's called ARPA-H. This new sprint will accelerate generation of discoveries This is their expertise, this is their function. And they're going to move discoveries from early stage proofs of concept to products that are ready to be commercialized. They look at both ends of that spectrum, including home-based affordable products. And innovators have responded to ARPA-H in an unprecedented number of applications that are now being reviewed for funding, and announcements will be made within this year. And so we started by asking federal agencies and departments what they can do now to close the knowledge gap on women's health. We listened to the community writ large about treatments and prevention strategies they want and need. And we sought expertise to learn what science can do to make positive change. Importantly, I think that it's very useful to say as well that Dr. Biden spent a lot of time traveling the country and really seeking the perspective of research experts. And it was really since the initiative was launched that Dr. Jill Biden has been at the lead. And we've traveled from California to Illinois, to Georgia, to Massachusetts, to Colorado, visiting research institutions and speaking directly with women and innovators about their work and their goals. And so it really was in this process that I'm describing to you that we came to these three major areas or themes that I'm talking about with you today. And Dr. Biden's involvement has been invaluable. And so we sought these kinds of consultations, these listening sessions, these lab tours. We did all of this to move forward in an informed way. And during his State of the Union address, the president then called on Congress to make a transformative investment for women's health research based on what we learned. And it would serve two major functions. If we receive this money through Congress, first, it would establish what's called a central fund for women's health at the National Institutes of Health that would advance interdisciplinary research in women's health. Another of those three occurring themes, in addition to bringing products more rapidly to the public and to clinical care providers. And this central fund would promote different areas of science to work together to answer complex questions that could cut across NIH institutes, these more siloed, important but siloed areas of work, and don't explicitly fit into the way we typically structure research. So they would really employ the enormous bank of data, information, expertise that exists and help us work across all of those areas that do extraordinary work and have led to many, many discoveries. And now, as we'll begin working with Congress to secure these investments, we're also moving forward on actionable recommendations. And as I think about it, there's one other thing. I mentioned to you that there were two things that this money would accomplish. The first was the central fund that I just described, but the center is for innovation that could exist around the country is also a very important aspect to this. If this money were available, if these funds were available, then there also would be the creation of a nationwide network in many states across the nation that would focus on research centers of excellence and innovation in women's health. And they would also focus specifically on the translation of discoveries into clinical care. So, as I say, I wanted to keep you up to date on these actionable recommendations required by the presidential memorandum. And recently unveiled are more than 20 new actions and commitments that you can read about, certainly in greater depth, through the White House press room website. And these 20 new actions came from every federal agency that was named in the memorandum. And we have found great interest, great excitement across all of these members of the initiative. And I just give you two examples in the interest of time. The first is the National Institutes of Health has stepped forward, as always, to launch a new nationwide effort to close gaps in women's health research across the lifespan. So a focus more about the transitions and the lifespan of women. And that will be initially supported by $200 million from the NIH budget beginning in 2025. The National Science Foundation issued a call for research applications focused entirely on women's health topics for the very first time. These are changes, palpable and important changes. And these changes are occurring even as the President directs additional action within the government through his executive order on women's health research and innovation that he issued on March 18th, 2024, that directs the most comprehensive set of executive actions ever taken to advance research on women's health, and in which the President reiterates a commitment to the third recurring theme, namely that existing research gaps mean that we know far too little about women's health across women's lifespans, and those gaps are even more prominent for women of color, older women, and women with disabilities. Through this executive order, the President is directing the members of the initiative to do three things. First, integrate women's health research across the federal government research portfolio. That's such an important word, that word integrate. Not just add on, integrate it. By ensuring common research and data standards that enhance the study of women's health. And not just the inclusion of women, but consideration of women's health in the development of study design, as well as in data collection and analysis, so we have outcomes specifically on women as well as men. Secondly, prioritize investments in women's health research with a focus on driving innovation, including through entities like ARPA-H, and also the Small Business Innovation Research Program that exists within the NIH. And third, galvanize new research on the understudied area of women's midlife by launching a comprehensive research agenda related to menopause and, equally important, disorders and conditions that often occur after menopause, like osteoporosis and heart attacks. Or, thank you, or are more likely to be diagnosed after menopause, such as Alzheimer's disease. And fourth, because I did tell you there were four. No, I told you there were three by mistake. So. And the fourth, regularly assess unmet needs in women's health research by assessing gaps in federal funding and identify changes that are needed to support women's health research, which is now being done through collaborative efforts of the Office of Management and Budget and the Gender Policy Council. And there is more to come. To fully realize this opportunity, a word that I've heard here and is the right word, these are opportunities, as Jane said, calls to action and opportunities. We need to develop ways to work together across sectors and industries to ensure that all of us, government, research centers, advocacy organizations, foundations, philanthropy, and the private sector are doing everything we can to close research gaps in women's health and improve women's lives. And this will pay benefits, because as women's health improves, the health of the nation thrives. On that note, I want to take a step back from this snapshot that I have presented and speak to you for a moment about how meaningful this work is and how meaningful the First Lady's leadership is for the field of women's health research. As a clinician, a researcher, and the founder and director of the Women's Health Research Center at Yale University School of Medicine, My life's work really has been dedicated to improving women's health by improving the research that we do on conditions that uniquely, disproportionately, or differently impact women. And never before has there been such a comprehensive effort from the federal government to spur innovation in women's health and ensure that relevant federally funded health research works harder for women. This is an enormous opportunity for important positive change in ensuring that everyone can benefit from scientific innovation. And we are very excited about generating clinically relevant data on women that informs care and improving the lives of women, men, and families all across the country. And thanks to the First Lady's leadership, the initiative will continue taking action so that we have the answers we need when it comes to health. And with that, I thank all of you for the work you do and for caring about the health and lives of women. And now I would turn it back to Jane.
Okay, now it is my pleasure to follow up Dr. Missouri's inspiring talk with introducing our next panel. We have Dr. Gigi El-Bayoumi, who is, I know firsthand, an incredible primary care physician. She is the founder of the Rodham Institute, and she is affiliated with the Georgetown Medical Center. We have Dr. Deb Richter, who is known throughout the state as one of the leaders in terms of single-payer health care. And we have Dr. Stephen Higgins, who's the chair of the Vermont Center for Behavioral and Health. Please come to the stage. Please welcome our panel. Thank you.
Okay. Good morning, everyone. Good. Can we do that again? Good morning, everyone. Great. Is it possible to get the lights a little bit, because I don't want anybody to fall asleep. Hopefully nobody will. Good morning. I'm Gigi El-Bayoumi. I'm a general internist, and I'm going to be Medicare eligible in a couple of months, and I am so excited about that. I not only see patients, and my patients range from 16 to 106. 106-year-old died, and every time she would come in, she goes, "When am I going to die already?" Most centurions are not like that, actually. They're very optimistic. But also I take care of political elite, some of them are here, but from all parts of the spectrum, even a couple of war criminals in the past and present. But also I take care of people with fee-for-service insurance, Medicaid, and Medicare, homeless patients as well. I'm also an educator, medical educator, so I train medical students, residents, and fellows. I'm from Michigan. I was born in Florida, raised in Michigan, and I'm of Egyptian heritage. And when I came to Washington, D.C. almost 40 years ago, I chose to come to D.C. because it was Chocolate City. 86% of the people who live there are African Americans. That number has reduced to 46%. I don't know how much you know about Washington, D.C., but it's really important that you read about the history of it. It was actually one of the places that was on the Underground Railroad stops, and it actually was very progressive. Actually, the port, part of Alexandria, used to be part of Washington, D.C., and what happened is that the white landowners didn't like that, so they took Northern Virginia. All right, that's just sort of as background. Well, I mean, this is true. We don't have control of our own budget. Again, we don't have control of our own budget. We don't have representation in Congress. We have, shadow senators. And so all of our budget has to be approved by Congress. Now, I think that's going to change when it becomes white majority. No, truly. So I want to give you a couple of quotes because I think that this is important. Being of Egyptian heritage, there is nothing new under the sun. We keep discovering or rediscovering models. And so when we're talking about these issues, we have to look at solutions overseas and before our time. I'm going to tell you about one person, a woman from Rwanda. She decided that there should be no more plastic bags. And guess what? Rwanda no longer has plastic bags. One person. So really making sure that we study current and previous examples, I think, is key. Second thing is, how many people, this is going to be age-related, how many people know Curtis Mayfield? Okay, good. One of his songs is, "If there's a hell below, we're all going to go." So that brings me to sort of the second principle. We are all in it together. I mean, we heard a very eloquent presentation yesterday about climate change, and I think that's the theme. So let me tell you about Washington, D.C., and why I decided to establish the Rodham Institute 10 years ago. The Rodham Institute, by the way, is something I founded. I named it for my patient, Dorothy Rodham. Please read about her story, because she epitomizes how somebody who has really a horrific childhood, how education really helped her. So please read about her. So the Rodham Institute is dedicated to improving health equity through education and community partnerships. We have 181 community partners. When we first started out, listening sessions, all over the city to find, not all over the city, in wards 7 and 8, primarily, poorest wards. So DC is shaped like a diamond, right? There is the Potomac on this side, and then here is the Anacostia River. So Anacostia is predominantly African American, although that's changing as well. There's Ward 7, which is a ward that a lot of retirees, government retirees, homeowners, that's again changing, and Ward 8, which is the poorest of the poor. Here's some statistics. If you live in Georgetown, on average, you can expect to live 94 years. If you live in Anacostia, it's 66 and a half. That is the largest disparity in the United States of America over a 10-mile span. Average for urban areas is 15, 16, 17. But averages don't tell the whole story. If you live in Ward 8, you live in the highest per capita part of the country, where there's HIV, end-stage kidney disease, and cancer deaths. And if you live in Ward 8, you are living in a place where it's the same HIV rate as Namibia, where the infant mortality rate is the same as Cambodia and El Salvador. There is this inflated sense of ourselves as Americans. We're number one. Well, in healthcare, we were number 37 before COVID, and we're now number 43. Yay, we're 43, And of course, in terms of expenditures, we know the story. I don't need to go into that. So what if a woman is pregnant in Ward 8? Well, she is going to live in one of the most polluted places, and actually environmental health or lack of environmental health is a real issue. Ward 8 is where dumping occurs, and there's no kind of monitoring, sadly, by the city. And we have an African-American mayor, right? Second, she would have to take 3 buses to get to the side of town where I live, where she can get prenatal care. And then I want to talk about something which I think is so important. Yes, access is an issue. Yes, the social determinants of health, which really determine 80% of our life expectancy, such as education, such as the economic health of where we live, the water that we drink, the food that we eat, all of that. But there is something that's always missing in those discussions, and that is the dignity of the human being we're in front of. We're doing a study right now with our friends at Pennsylvania Avenue Baptist Church. We're co-creating a curriculum to see how we can increase the rates of colon cancer screening. So the first thing that we did was we did a focus group, and these are learners from the medical side, meaning medical students, not nurses or other residents and fellows, and the health ministry. The first part was we all did a survey, and then one of the women said, I would have answered this survey differently if it was for me versus my brother. Okay, my brother died a year ago from colon cancer, and on the next to the last day of his death, the physician walks in and she says, you're going to die, how would you like to die? Another patient or a person from the health ministry who's, I think, in her late 70s, early 80s, she's got diabetes. She went to a podiatrist. Physicians and other specialties can be equally as obnoxious. She was sitting there. She had her, her socks and shoes off, waiting to be seen. The podiatrist looks in and says, soak your feet. She shared with us what she was thinking. Was I unclean? Did I do anything? And mind you, this is a lady with diabetes. It took her 3 years to make an appointment with a different podiatrist. So let's start when we're having, and this I'm preaching to the choir, respecting the dignity and the humanity of individuals that we're dealing with. And we have to be consistent in whatever venue that we are in, whether it's people that are supporting this wonderful conference, the staff that we work with, the patients that we see, whatever. Now, let's talk about good things, because I think one of the untold stories, especially from the academic side, is that there are lots of successes. First of all, there's a lot of activity in leadership, and the leadership is quite diverse in Wards 7 and 8. Lots of women leading this. And I would say that women's health impacts everybody's health. I'll tell you, in a heterosexual marriage, when men get married, guess what happens to their health? When women get married, guess what happens to their health? No, this is true. This is research-based. So let me tell you in finishing, because I told Dr. Richter that I have the gift of gab, and she had to signal me when I have 5 minutes. And we can talk a little bit more during the panel about these. But the solutions are amazing, and one of the groups that is underrepresented, but not underrepresented in community work, are other clinicians, nurses, doulas, midwives. Guess what? When a woman is pregnant and is getting her care, midwives have better outcomes than physicians, okay? One of my nieces is pregnant, she's seeing a midwife, and I really encouraged her and supported her decision with physician backup. So lots of doulas, lots of nurse-led initiatives. One of the nursing-led initiatives is from my friend, Dr. Erin Athey, who's a nurse practitioner. She talked with DC Housing and got them to basically donate 4 two-bedroom apartments in 4 different housing developments, and she's transformed them into clinics so that care can be given. Another women-led initiative is, of course, food. And again, we'll talk more about that. Women's health is everybody's health. And I want to just finish up by talking about Black women. Because whenever you do an intervention for Black women, guess what? White women's health improves. So some of the statistics that we heard, I'm going to just finish up by saying endometriosis is more common among Black women. And guess what? They're always told that they have pelvic inflammatory disease. Multiple sclerosis, number 1 in Black women. Lupus, again, disproportionate. So I'm going to just finish up by acknowledging 3 people. Dr. Vivian Pinn, who established the Office of Research, and then Dr. Bernadette Healy, who established the Women's Health Initiative. Everything old is new again. They're just versions 1.0, 2.0, et cetera. And then finally, Dr. Crystal Dixon, who is, I can't remember if she's now at Wake Forest, who did a study looking at how to improve the care and screening of women in cervical cancer and mammography. Not only did that improve the outcomes for Black women, but also for all women. So there are minorities within minorities, and if we focus on that, everybody's health improves. I'm so looking forward to having a discussion and from hearing from the rest of my illustrious colleagues here. So I'm going to turn things over to Dr. Richter. Thank you for your attention. That's Dr. Higgins.
So I advance the slides with this? Okay. So I'm from the University of Vermont, and I'm going to be talking about women's health and trying to advance it by addressing rural disparities in cigarette smoking. So first thing I want to point out is even though we have to attend to the crisis with opiate epidemic and other serious drug use problems, cigarettes are still killing almost 500,000 Americans every year. So it's a serious problem, and it's a problem that has really become more serious in our rural populations. So I was very excited by Dr. Missouri's, what she shared about the Women's Health Initiative. I've been working in women's health for at least the last 20 years, and I bring two examples of studies on the rural disparities. And first, I just want to show you the epidemiology, what it looks like. And I'm focusing on women of reproductive age. Why? Because of the risk for multi-generational adverse effects. So I'm going to quickly go advance my slides if I can figure out how to do it. Let's see. To this study on using the National Survey on Drug Use and Health, which is a nationally representative survey of U.S. citizens, and it's looking at people aged 12 years and above. And what we're going to do is first look at smoking, current smoking status. That just means that you've smoked in the past 30 days and you've smoked at least 100 cigarettes in your lifetime. And then we're also going to look at, and we're going to compare rural women of reproductive age against urban women of reproductive age. And then we're going to look at things, something called quit ratios, which is simply how many, it's former smokers. You met criteria for lifetime smoking, but you haven't smoked in the past year. And so the data, and then we're going to adjust for race, ethnicity, education, and income to show that the rural disparity is not just about those, but it's what we think is a lack of access to evidence-based treatment, smoking cessation, enforcement of tobacco regulations, that sort of thing that is contributing to this disparity. Okay, so the rust color are the rural women, and the blue are the urban women, separated, not pregnant and pregnant, and you can see very clearly prevalence is way higher in the rural than the urban women, and this is 18 continuous years just because we wanted to look at time trends using common methods, and that was the period we could look at. And if you just look at the non-pregnant, what you see is not only are the urban women less likely to be smoking, but the trend is steeper, the decline is steeper, so the disparity is growing. And then when you look at the pregnant women, there's more variability just because the numbers are smaller. Only about 4% of U.S. women are pregnant at any one time. But you see the same pattern. So we have a problem. And what I want to do, I'll quickly show you the same thing for former smokers. Now it flips. More former smokers urban than rural. Okay, so what can we do about it? I'm going to just show you one study that we have conducted recently, taken on perinatal women, pregnant women in particular. Well, I mean, I'm particularly interested in the pregnant part of the perinatal status. So I think many of you already know this, but smoking is the leading preventable cause of poor pregnancy outcomes. And I already showed you the disadvantage. And we have treatments that are available for them, smoking cessation treatments. But the quit rates are awful. About 10% of the women will quit when they get one of these treatments. It's usually a referral to a quit line. So think about what kind of treatment should we be happy about when 1 in 10 benefit from the treatment? So what we've experimented with for the last 20 years is, can you incentivize behavior change in the pregnant women? And the answer is you can, but I'll show you it from a recent study we did. And I want to just try to move fast so we have a chance for a Q&A. But the incentive model we're using are vouchers exchangeable for retail items, and we offer them to the women from around late first trimester through 12 weeks postpartum. These vouchers are provided contingent on biochemical test results, and so we're not just giving them away willy-nilly. They have to show us they haven't smoked recently, and these vouchers are available for about 9 months. If someone abstained throughout, they could earn about $1,100. But the results I'm going to show we get for only $500 on average. That's a pittance in healthcare costs today, but the results are quite impressive, I think. So the blue bars, this is in the top panel there. Just to keep things simple, the blue bars are the people who are incentivized. The red bars are the usual, or we're calling it best practices, but without incentives. So just by adding the incentives onto the best practices, you get up to about 40% of the women to quit during the pregnancy, and that effect tapers some after delivery, but remains above if you've got incentives, meaning the women are en route to lifetime quitting. And in the bottom panel, all I'm showing you is that it's a very reliable effect. We've done 5 trials, and they're summarized in the bottom panel. All right, so this is I'm especially encouraged by this finding. This is the percent of women who have small for gestational age deliveries, so they're called SGA deliveries, and SGA does 2 things at least. It increases the risk for SIDS, sudden infant death, in the first year, and it also puts the child on a path for metabolic disorder later in life. So really serious adverse outcomes. The upper and lower panels, the red is you didn't get incentivized, the blue is you did. You can cut SGA in half. So important outcome. You can do something about it. You incentivize outcomes, and not with large incentives. Okay, so to wrap up, there's robust empirical evidence that financial incentives are efficacious, cost-effective. We did cost-effective analyses. $4 to $12 recovered for every $1 invested in this incentive intervention. The United Kingdom can move faster. I'm looking at Senator Sanders. I'm sure he understands why they can move faster with this kind of thing. They already announced they're going nationwide with this intervention. We're making progress. I'm meeting next week with Vermont officials. We're inching our way along, but we're getting there. Financial incentives are efficacious for other substance use disorders, including stimulant use disorder. California has a statewide implementation study underway. Vermont and other states are moving forward. There's a sound scientific rationale for why financial incentives work. They stimulate the same brain reward centers that abuse drugs stimulate to cause addiction. And then they also accommodate the tendency for people with substance use disorders to need immediate rewards versus delayed rewards. So this kind of provides some healthy immediate rewards for healthy choices. Lastly, I want to end on a positive note. I'm very excited about this treatment moving forward, including here in Vermont. The incentive-based treatment, we're using it, we're moving forward with the pregnant women, but we're also moving with illicit drugs here in Vermont. But if we're going to do better with reducing health disparities for substance use disorders, we have to learn to move evidence-based treatments into community use faster. So the first study on psychomotor stimulants and incentives we published in 1991. And on the smoking during pregnancy, 2004. So it's 20 and 30 years to get these out into the community. Better late than never, but I think we can do better. Thank you.
I'm just switching it over to your slides. Yes. How do I advance?
And hopefully zero in on a specific thing that we can do, at least here in Vermont, to start the ball rolling again with healthcare reform. Decades ago, Walter Cronkite once said that the U.S. healthcare system is neither healthy nor caring nor a system. And decades later, it's still true. But I think that's the bad news. The good news is that it is possible to cover every single Vermonter, every single American with comprehensive coverage without spending a penny more than we're spending currently. That we know, we've known for a long time. We've had many, many studies. Now, don't panic. I just have a few slides. Okay, I know how that must look. But anyway, we're spending, as Bernie said last night, twice what other countries are spending on average in terms of percentage of GDP and in per capita. And again, a lot of this is unnecessary spending, and I'll talk briefly about that. But in addition, I think it's important for us to understand that we pay the highest healthcare taxes in the industrialized world. If you see that area in yellow, that's what we spend in taxes to pay for this dysfunctional healthcare system. In addition, the private spending, so that's health insurance and out-of-pocket spending, for a total of $13,420 per person. We could buy any of these other healthcare systems. That's what their spending is in total. And they cover everyone, and they do better. Our life expectancy is dismal compared to these other industrialized countries that cover everyone for half the cost per person. Infant mortality is disgraceful. And again, poor women do far worse, and poor infants. And U.S. mothers, again, poor mothers do much worse. So we really have nothing to brag about. So we're spending twice as much. Our outcomes aren't as good. And let's keep in mind that the spending crowds out all the other things that we're talking about. Housing, social programs, drug rehab programs, education. Those things can be addressed if we were spending less money over time on health care. So if we're not spending it on, where are we, who are we spending the money on? It's certainly not on health insurance for everyone, right? So this is basically a study done in 2022 that showed 40% of insured Vermonters were underinsured, meaning a major illness would cause financial bankruptcy. I take care of patients. I'm an addiction medicine specialist now, and I take care of patients with opioid addiction, alcoholism, cocaine addiction. And what this means now is being underinsured, patients are losing their Medicaid. So what does that mean if you're in treatment? Because if you're in treatment for your addiction, you're less likely to overdose and die. So what happens? You're on Medicaid, you lose your Medicaid, and you have a choice of either buying the coverage, which doesn't cover anything, or paying for housing or paying for food, and ending up like a few of my patients in a tent. One of my patients is, his girlfriend is about to give birth, and they no longer have housing. So in a few weeks, she may end up in a tent, he and she and the baby. I don't know yet. Maybe they'll be able to get a last-minute hotel. But what kind of an upbringing is that? And kids are basically shepherded from one hotel to another. I see this all the time. Now try to remain sober in a tent city. When people are using drugs around you, try to remain sober. These are things that we are crowding out by paying unnecessary, sorry about that. So if we're not spending it on people, what are we spending it on? Well, it turns out we are spending an enormous amount of money on administration. So this is Duke University Hospital Medical Center, 957 beds with 1,600 billing clerks. And a hospital, major hospital, a bigger hospital in Canada with 1,200 beds, 7 billing clerks. That's actually for just Americans who wander across the border. Otherwise, basically, they're globally budgeted. They know what their revenue is every month. So this is where we're spending a lot of our money. So 31 to 35% of the healthcare dollar goes for this. It turns out healthcare is a great jobs program for administrators and billing clerks. And in fact, managers, which we've seen since 1970, comparing the number of managers and healthcare administrators, we've seen more than a 4,000% increase since 1970. More than 4,000% increase. And yet at the same time, that little yellow is the amount increase in the number of doctors. So these are folks that do not administer health care. They don't take your blood pressure. They don't prescribe your medication. They don't take care of your diabetes. They just sort of manage and drive us absolutely crazy. And again, you want to know why nobody's going into primary care? Managers. So what should we do? Well, it turns out that in 2011, Vermont passed single payer, essentially Act 48, which basically the bill was supposed to provide comprehensive coverage, publicly funded coverage to all Vermonters. It was never implemented, but it is still the law. So what should we do? Well, we have been trying since, let's see, the governor and the legislature dropped the whole ball in 2014, and we've been trying since 2015 to get a universal primary care bill passed. We made it a few times. We did get a study done. But why primary care? Well, it turns out if everyone has access to a primary care clinician, it is the only sector that has been shown to improve population health, lowers infant mortality. We know this. This is not disputed, all of these benefits. Not only that, it's cheap. It turns out, we did the study. It was less than 6% of total, and that included mental health services, outpatient mental health services, and outpatient substance use disorder services. All included, because that's our definition of primary care in Vermont, including those other services. We could do this, sounds like a lot, for $200 million. Again, we're already spending, that would be a net increase of $60 million per year. Now, this is a small price to pay, a huge return on investment, and it is something that we could do at the state level. We had a bill that sat on the wall this year, 59 co-sponsors in the House, and 10 co-sponsors in the Senate, so it's H-156 and S-74. We intend to push for it again. This is, again, a relatively small ask when you consider that Vermont is going to spend $6.8 billion on health care. And so to add a net $60 million in terms of taxes. We're replacing, however, no more premium. You do not need a universal primary care. What does that mean? It means that every Vermonter would not need private health insurance for primary care, mental health, and substance use disorder services. That would be removed from the health insurance. And we would publicly fund it and extend it to everyone. And then over time, the next year, we're adding preventive dental and eye care. The year after that, we can keep adding sectors of care. Now, that was because the legislature had no appetite for the whole thing at once. That's why I'd rather it all be done at once. But it is a heavy lift. But this is possible. So we have a Universal Healthcare Caucus that we've started. Again, Representative Brian Chena, I believe he's here. Yes, okay. And if anyone, we're asking all Vermonters, we have doctors, we have nurses, we have representatives. As part of this caucus, we've met 3 times. And you can meet by Zoom or whatever, join us, and help us push forward universal primary care. Thank you. Do we have time for questions?
I don't know, what is our time?
Yeah, do we have time for questions, or should we just, what's?
Wrap up with your discussion.
Okay.
All right.
Okay.
I do. There's a lot that I could have spoken about, but I want to say a couple of things. First of all, it's important to do women's health research, just like minority health research, because there are things that are different. One of them is alcohol use. Women should not drink more than 7 drinks in a week. It doesn't matter if it's beer, wine, or hard liquor, because cancer rates go up. Men, 14. Since COVID, there have been drinking parties among women. The number of liver transplants has gone up. I actually just had a patient die of liver failure. Let me talk about an excellent model. You know, yesterday there was discussion that we can do this. Well, we did it during COVID. World crisis, everybody came together from science and advocacy groups and communities. I mean, it's pretty remarkable that within, a year, give or take, you had a vaccine that was available. I mean, we were lucky that the virus is extremely simple. So let me tell you about the Black Coalition Against COVID, of which I'm a founding member. So among African American patients, the numbers were low. So what was the model that we used to improve those numbers? We had the 4 historically Black medical schools, we had nurses, we had people from the hip-hop community, the go-go community, the fraternity, sororities, the garbage workers. We had everybody at the table. The model that we used, we did a 1-day mass vaccination event in Ward 8, 900 people were vaccinated. What was the model that we used? Did a train the trainers model. I did 9 19-minute sessions with one of the large community-based groups that does services. What did that do? It increased the educational, social, capital of that group, so that if Rodham disappeared tomorrow, they still have that knowledge. They were the ones that were educating. So I can't stress enough, community needs to be at the table. The people that are closest to the problem know the solutions. We leverage science and our different fields of expertise to make things happen. But if we're going to make a difference in health disparities and women's health, women are the caretakers for the family. Women have the greatest burdens in terms of navigating everything, because our corpus callosum, which connects the 2 parts of the brain, is this big. So there's, that so much stuff that we're handling. So women's health is family health, is children's health.
Yes. Well, I think I summarized with my talk, but basically I just want to give people hope. I think this entire audience is reason for inspiration. All the conversations this morning, people truly care, and I do think the majority of American people care. We need to get more people involved and give people hope that we can strive to help each other and live, again, a better life, and people deserve that.
I'll end on the point, my last point in my presentation about prioritizing the movement of evidence-based treatments for substance use disorders into community clinics. And with the opioid crisis, we did a reasonably good job on medications, but medications alone are not adequate. And with behavioral interventions, the incentives are an example. It has been too slow, and these delays cost people's lives. So I would leave it there. We just have to do better in getting the community clinics equipped with evidence-based treatment.
So what Fauci said, which is so important, science implementation is key. I would urge everybody to read, if you don't already know, about what he did during the AIDS epidemic in terms of engaging the people that were most affected. And I would say, if you want to improve people's life expectancy by 10 years, make sure they graduate from high school.
Yeah. Okay. Very good. We're just going to take a shorter break this time. The next panel is going to be in this room in 5 minutes, so you can stand up and stretch, talk among yourselves, but then please come back for the next panel. It should be incredibly interesting. Thank you so much. You've given us so much to think about: research, science, and incentives, behavioral health. Thank you. Okay, folks, sit down, please. We need to start. We'll be here until midnight. Okay, so medical price transparency is a concept and a reality only for the last few years. We've only begun to make a difference. The organization that has made the most difference in having this be brought to the forefront, especially in the eyes of Congress, is patientsrightsadvocacy.org. And the person that I'm going to introduce is Dr. Cynthia Fisher, who is the chair of patientrightsadvocacy.org. And she's going to we're going to show a video first done by that organization. She'll come up right afterwards to give a few remarks. Thank you very much. Please welcome Patient Rights Advocacy.
Yeah. That's the correct source, yeah?
A troubling new trend is coming to a business near you. Prices are hidden, and consumers are left guessing what they're on the hook for paying.
When they ask for a price, we give them an estimate. Then we bill them whatever we want.
It's called the hospital pricing method, long implemented by hospitals and insurance companies to create unprecedented wealth.
Yeah, we don't do prices. We'll send you a bill.
Okay. Okay. We are going to pivot, and we will hear from Dr. Cynthia Fisher and give some remarks right now, from price transparency, momentum to revolution. Come on up.
Thank you, Jane. It's an honor to be here today and share with you that there is an incredible movement happening since the great reveal of the rights of all of us to know prices in healthcare before we get care and prices in healthcare before we get our bills. 3.5 years ago, all hospitals and all insurance companies have to show their actual upfront prices online so that we can see widely the variation in prices across our country and even in the same hospitals. This law was actually so bipartisanly supported because it was sitting on the shelf from the Affordable Care Act for years, collecting dust, that we as patients have the right to know all prices up front. And believe it or not, it was Obama and Biden that had that language in the law. And it was the Trump administration that then made it into rule of law. And then President Biden saw that the hospitals were not yet fully complying with the law to post all of their prices and make it readily available. So he upped the fines to hospitals to $2 million per hospital for not showing their prices, and started an anti-competitive practice within the White House to go after the need for competition and for us to be able to have access to these prices. Each one of us over the years has had a story, either in our own family or with our family and friends, of experiencing an overcharge way beyond what we would have expected to pay for care. And 100 million Americans have medical debt in this country. That means 1/3 of us have had medical debt that perhaps we can't afford to pay. In 21 states in this country, hospitals are suing patients for their medical debt and taking them to court. What's happening in those courtrooms? Do you think those patients can afford a lawyer when they can't afford to pay those thousands and thousands of medical bills? They are standing unrepresented against 2 hospital lawyers and 2 billing officers and the judge. And they are ill-equipped when they are ill-informed. And what took them to the hospital was likely illness in the first place. When we have actual access to prices, we have the ability in that courtroom to know whether the bill is correct or not. I mean, what other area of our life do we not know what prices are? In every other facet of our life, we get to choose and be empowered with choice because we know prices. And then we as consumers have fairness of utilizing our choice to be in control of our decisions and control of our finances when we make those decisions, but not in healthcare. And as it was so said so many times, that the healthcare system is broken, severely broken, because the true purchasers of all of healthcare is every one of us as patients, as families, and every one of us as true purchasers is the American worker who pays for all of healthcare. We pay out of our paychecks of foregone wages for the premium benefits shared with our employer, whether it's the school district we're working for or the municipality, the state, or it's a manufacturer here. And we pay, as workers, taxes. When government provides health care to Medicaid and Medicare, into the indigent, or into any type of other programs, we, the taxpayers, are the government, because we're paying out of our hard-earned earnings and our hard-earned duty as citizens to pay for the security of all. And this can all change, and it is changing. Because what do prices in healthcare that we now have in law, and who sued? When the Trump administration said Obama administration was right to make prices in law, and we're going to make it happen, and Biden weighed in, who sued? The hospitals sued. They sued to keep prices secret. I know this morning there was a big talk about the big oil industry, but let's talk about the big healthcare industry. This is big healthcare. And capitalism doesn't work at all when the actual consumer is held blind to no prices, blindsided by outrageously priced charges that they never expected to pay. And how, when we get our care, every time we get care, we have to pay by first signing a blank check. We can't even get our surgery or get into that doctor's office unless we sign now a digital signature. And we don't even get a printout of what we're signing. We're signing away our rights to know those prices up front. We're signing our rights to give them the big industry of healthcare to sell and broker all of our health information for their benefit. And we're selling away our rights to say that when we sign in, that we are responsible to pay whatever they choose to charge us. That's extortion. I mean, can you imagine handing a credit card to a teenager and just say, spend whatever you want? I won't even be able to look at the bill. Well, guess who the other, I can't imagine, right? You have your family on a budget. But think about it. It's not just us as consumers. And I think we've been in these courtrooms across the country. And we've done market research across the country. And we ask one question. For $200, we bring people in and we say, tell us about health care. Well, let me tell you, we go through a lot of tissue boxes. And everyone has a story. And in the courtrooms, where people are told to go back to the back of the courthouse and negotiate their garnished wages, when someone's making $14 an hour and the hospital garnishes half of their wages, $7 an hour, they can't afford to put food on the table or keep their home. We see people in Florida, so housing has gone up, almost tripled in some of those houses. And who has the most liens on those houses? In the death of a parent or a grandparent and the family is all living there? The hospitals. They're putting liens on those properties. So let's talk about housing crisis. It's the big healthcare system where I know Senator Sanders said last night that we have unbridled greed that's taken place. And what prices do is they're the bridge to a whole new world. Because there's another consumer in this room, and it's our employers and our unions and us who buy, through premiums, health insurance. We buy it on the exchange as an individual, or we get health care that we as workers share those premium costs. Those premium costs on the monthly basis, that comes out of what is foregone wages. Most companies and businesses and organizations share like a 60-40 or 70-30, where 30% is paid by the worker, 70% by the employer. But if those costs were controlled and we were able to see those pricing, we were able to make choices and compare plans and see prices, we can drive them down. And what I'm here to talk to you about today and bring on the panel is a great group of individuals that have been working to drive down the cost of care. And let me tell you, price transparency is working. And the first place it's working is right here in Vermont. We looked at the hospital pricing files, and only across the country, since the law became rule for hospitals to show prices, only about 35% of all hospitals are fully compliant with the law. And in Vermont, we looked at the hospitals here, and they're almost complying, but we're tough graders. Because what's wrong here with the Vermont hospitals is they're not showing, we have zero full compliance in the ones that we looked at, because they're not fully showing every single insurance plan prices. So that means some of the consumers here are discriminated against because they can't find the prices for their plan. So by law, they have to show every single insurance plan so we can compare the prices and compare to the cash price, the discounted cash price. And what we're finding is we are finding that in the same hospitals, prices vary on average 10 times difference. And across the hospitals in the same state, we looked at 100 hospitals across the country in 10 states, 10 hospitals each. Prices vary across hospitals by 33 times. Now, we talked about big oil and gas, but could you imagine going to the gas station and paying $50 to fill your tank, and then Jane pulls in behind me, and she's going to go fill her tank, but in the same gas station, but she has to pay 10 times more. So she pays $500 with the same gas. Now, across the street, Chris goes across the street because she thinks she's going to save 2 cents a gallon, so she drives to that station. And instead, think of it if it were a hospital here in Vermont, 30-some times difference. For the same amount of gas, she'd pay $1,500. None of us would put up with that in gas or the grocery store or anywhere else. And what we're finding is an MRI here in Vermont, the lowest price plan MRI is $242 by insurance plan. And the other MRIs in this another plan, the highest in the same hospital, is $3,400. That's the same machine, the same technician in the same hospital. Now, if all employers and all unions knew that they were seeing these prices and they were looking at the Medicare and Medicaid prices and comparing it, everybody would want to see, well, wait, why can't we get a price that's near the Medicare and Medicaid price? Because we know the hospitals are making a profit. It might be a smaller profit, but it might be a fair and reasonable profit off of the government-sponsored plans. But when the employers get the great reveal, that's game-changing. And so net-net, what we're seeing is colonoscopies, we're finding out the fair market price may be around $1,000 all in. And another patient in that hospital may be charged $12,000. That's outrage. So the employers that are changing the game are like Harris Rosen in Orlando, Florida. 6,000 covered lives, owns hotels, and he direct contracted with a lot of the hospitals. They got to know the data, and they're paying less than $10,000 for a family of 4 for all of their employees for coverage all year. And they've upped primary care substantially, occupational therapy, everything, and dental, everything for their employees. Osceola School District, not Osceola, excuse me. Yeah, Osceola School District in Orlando had a $12 million deficit for their 14,000 covered lives. They couldn't afford health care. These are teachers. They were ranked 8th worst in Florida. They went to Rosen Hotels and they said, please help us be able to figure out what you're doing. Within 3 years, the first year they saved $9 million, the second, $21 million, and the third, $41 million, by getting to reverse engineer their prices. Those monies went back into bettering the school, the teachers, the programs, wages. And what else is happening? Prices allow us to shop and compare these prices up front. And the other thing, they protect patients from overcharges. Now, we have gone to courtrooms and provided pro bono lawyers, and our own team now knows how to also help on medical bills. And by accessing prices in markets across the country, when patients come into us, we're able to see that almost every bill is an overcharge. And when you ask for the itemized list and you get the itemized list, you can fight those bills. And so we were able to help a woman who had Parkinson's, retired younger as a school teacher because of it, had a great health plan, needed her hysterectomy in Colorado. What did she do? She got an estimate. She asked for the price and what's her out-of-pocket. $5,000 estimate and a $500 copay. Confirmed it, took a picture of it, got it in writing from the hospital and the insurer. What happened in reality was the insurance company denied the claim, and the doctor charged $9,000 out of network, and the hospital had a lien on her home, put a lien because she couldn't pay the $74,000 bill. So after months, getting the bills, getting the itemized, we looked at the hospital pricing file, and it was indeed closer to $5,000. And indeed, it should have been covered all in. It was actually $8,000, and it would have been an $800 copay. But it took us with her about 4 to 5 months to get that lien off of her house. But prices empowered her. They saved her. They protected her. And it's happening across the country. And so I'd like to move toward the panel. And, you know, today we have some revolutionaries that are actually moving in this movement. And I'll do a shout out for Cora Upsall from SEIU 32BJ because the unions are leading this. And I'm not stealing your thunder, Cora, but 32BJ, before price transparency came into play, got all of the billing and claims data and reversed engineered with data analysts. What are we paying in New York City? What are we paying in New Jersey for over 200,000 members of their plan? And what were they able to do? They were able to redesign their plan, and Cora will tell you how, but they redesigned their plan, and they saved $35 million in the first year. In the second year, they saved over 33 again. And they're looking at this $100 million, and what did they do with it? They gave the highest raise for all of their workers. And they gave a premium holiday for their employers, for 2-month premium holiday. That's huge. And they give the biggest bonus ever, $3,000 to everyone. All of them. So this is the revolution, is all of us stepping into our big girl and big boy boots and us as consumers refusing to sign that blank check without having a price and ask for what is the Medicare price? What is the price for that service? And do not agree to sign away your home and your wages unless you're given those prices up front. And the second thing is to, when we get our bills, to never pay that first bill. Thank you, Marshall Allen. It's a book. God rest his soul, fought very hard to make sure patients knew that they have a right to itemize listing of what they're paying and not to pay it if it's overcharged, and even take the hospitals and the insurance companies to small claims because it's your money. But more importantly, too, we've got the employers and the unions who are leading the way, and they've woken up. They've woken, the bear has stopped hibernating, and Stockholm Syndrome's over, and we have all woken up to this revolution that is our money, it's our health, and we can drive the costs down. So at that, I want to thank you and bring up our panel.
So, panelists, I would like to introduce Chris Deacon, the former director of New Jersey State Healthcare Benefits, and to join Cynthia Fisher, Kevin Mora, co-founder of Power to the Patient, and Cora Opsall, who is with SEIU. They will tell us what the current impact of price transparency is and what the full potential to lower costs will be. Thank you very much.
Thanks, Jane. Clicker? Oh, how about if we play the video at the end, and we'll go to the slides. Thank you. This is such an incredible team because they're going to tell you about how we're winning, and I just love to win. I love to win for the, we want to win for the people because look what's happened. I mean, this was spoken of last night. We're at $4.5 trillion and ongoing for what the spend is in healthcare. That red line is our life expectancy. Yeah, that's our life expectancy on decline, and the blue line is the increased costs, and the little dip was during COVID when nobody was going to the hospital. Look at that. Okay, the United States is that in red, and we pay more for the worst quality of care compared to every other developed nation. Now think about that. We talked a lot about the unions and the workers, and last night about manufacturing, the need to bring more manufacturing back into this country and solar panels. How do we compete with all those developed nations as workers if we're paying that much more out of workers' paychecks for health care? We have to bring it back on par. And guess who's using our system from the 60s? Singapore. They're using the U.S. system of healthcare from the 60s. And here's where we see over time, the premiums costs have gone up with inflation, but not workers' wages. Workers' wages have been suppressed. And Cora, I'm going to go back. Cora, could you please share with us how the unions are leading the way and what price transparency means to workers' wages ongoing?
Good afternoon. My name is Cora Upsall. I'm the director of the 32BJ Health Fund. So we provide the benefits for the SEIU 32BJ union. It's 217,000 covered lives, mostly based in the New York City tri-state area, but up and down the eastern seaboard. And it's the largest property service union in the country. So it's your residential and commercial real estate workers, security workers, school workers, and airport workers. And it's a growing union. So I know yesterday there was a lot of talk about the growth of the union. And 32BJ is a growing union, and as the fund, it's my responsibility to provide benefits to these members. And our members have premium-free benefits, 100% paid for by the employers. But it's because of the work of the health fund that we're able to continue to offer this premium-free benefits. As you mentioned, Cynthia, the thing is, right now, we've done the math. In the last 10 years, healthcare as a percentage of total compensation has gone from 17% to 37% in the last 10 years. At that same time period, wages have gone up 54%, but healthcare costs have gone up 230%. It's untenable and unsustainable. And then when we think about that, what does that really mean to the workers? If healthcare costs had gone up at just the rate of inflation, the 32BJ union members would have had an annual $5,000 more in their check every year. That's food on your table, that's rent that you can pay, it's a vacation with your kids. And so when we think about healthcare costs and we think about wages and how does this work, it's like, I think unions are the tip of the spear because they acutely understand the concept of like total compensation. And everyone in here is an employer, and everyone in here understands that healthcare is a piece of that, but I think unions are uniquely situated to be able to do that.
Kevin, you've spent some time because the unions are actually getting together, right, on this whole cause. And you've been involved with, we'll hopefully be able to see some of the production work that you've done with Power to the Patients. But could you talk a little bit about what happens in New York, having the union seeing the good that SEIU 32BJ has done to put nearly $100 million back into their own enterprise plan, which is amazing, and how New York's looking at it from other unions' perspective.
Absolutely. Thank you. It's a pleasure to be here amongst like-minded individuals. Power to the Patient started because of a humanitarian issue, as Chuck D from Public Enemy calls it, an American humanitarian issue, which is not something we often hear, right? Humanitarian issues are for overseas, oftentimes in developing countries, but when you have a healthcare system, the basic infrastructure of a developed country, when you have a healthcare system that is almost unreasonable or irrational to enter because there's a complete void of prices that eventually will have an incredible impact on your financial health, right? So you enter a hospital, and as Cynthia brought up earlier, you're forced to sign this personal guarantee to say, we are going to implement a number of procedures and services, and eventually You're going to get a bill in the mail, and you're guaranteeing right now that you will pay for that bill. However, you don't get to see what any of the prices of these procedures are, or if you should be across town or next door, or ultimately the opportunity to price check to make sure that your bill is even accurate. So this is a humanitarian issue. This is not a partisan issue. This affects everybody. More marginalized communities in New York City. If you stand on any street corner in the Bronx, you will watch people walk down the street with a limp or in a wheelchair for decades that don't go and seek care or help or remedy for what ails them. Why? Because healthcare is not for them. They can't afford it. They don't want to be in a critical moment where they decide, do I pay my rent or do I pay this medical bill? Do I try and get out of this area or into a bigger apartment or send our first generation off to college, or do we pay this medical bill? And that includes preventative care. Why go and get a colonoscopy if the outcome could mean personal bankruptcy, right? So we're very much boots on the ground. We very much have found influential people to join us. Shepard Fairey, one of, probably the top 1 or 2 street artists in the planet. You may know him from your own activism work. He's always creating new artwork for civil rights and human rights. He created the Barack Obama Hope poster, which is now in the Smithsonian. He created the artwork for us, for price transparency and power to the patients. And we have now painted that artwork as a mural in 47 communities around the country, and that includes Nashville and Los Angeles and Seattle and Dallas and New York City. And tomorrow morning, a local artist named Mary Lacey paints this artwork as a mural right here in Burlington on the sides of, all 3 sides of the Barrio Cafe, which is on North Winooski Avenue. And I want to thank the local property owners, Chris and Sarah from Shoeless Management, for giving us that canvas so that we can connect Burlington to the rest of the communities around the country that are now understanding what it means when we don't have price transparency in healthcare. And it's been an honor to stand and to be boots on the ground with unions. There's 16 in New York City that together we've created a coalition, but certainly 32BJ is one of those. And the last thing I'll say before I hand this back off is, upcoming we have this presidential election, and certainly in this room, I think we keep hearing that it's election of decency or indecency, right? That's kind of the option. Well, healthcare price transparency needs to be discussed if we are to be decent, right? Because the number one cause for personal bankruptcy in this country, it's not junk fees, right? It's not going to Hertz and then hitting you with the $4.37 upcharge that you didn't know coming and they can't justify it to you. It's not paying too much for a Taylor Swift ticket, right? It's the lack of price transparency in healthcare, and medical debt is the number one, and it's not even close, the number one reason for personal bankruptcy in the United States, and it's not being adequately addressed right now. And that is indecent. Because what's happened here is, the last thing is healthcare provides non-discretionary services, right? Necessary procedures and services so that we can have proper health or so we can survive. And what's happening now, people are making a decision, a deliberate decision, to not seek medical care, to not take these non-discretionary procedures. And when non-discretionary becomes discretionary, we all have a real infrastructural issue in this country. Thank you.
Thanks, Kevin. Chris, thank you. I think one of the statistics is it's over 54% of people deny themselves care for fear of financial ruin, and they put off care. So we need to move it to the front of the curve, which was said earlier today with primary care and going and getting the care you need before you need it. Chris, you've worked with unions like SEIU 32BJ. Even as New York City is identified, they pay what, $10 billion a year in health care, and they've identified if they did what SEIU has done, they could save $2 billion a year. You saw that figure up on the screen that we're paying $4.5 trillion. It's been noted in so many journals, peer-reviewed, that 25% of that's just pure administrative waste. We looked at all those administrators and managers. You cut it out by having people not tolerate being overcharged and having the medical field compete just like every other market on price. What do prices bring? People want to know what they're going to get for that price. So then you get competition on quality and outcomes. But if we could look at saving that 25% a year, that's $1 trillion. You don't need to tax anyone. We just all need to become our own patient advocates in every employer and union to drive these costs down by $1 trillion a year and put it back into the pockets of the American people. That is a goal we can achieve. And Chris, maybe you want to tell us more about the employers that are.
Yeah, sure. So quickly, I'm a lawyer by training, but I no longer practice. I pivoted to healthcare and public service a few years ago. As Cynthia mentioned, I ran the state of New Jersey's public sector health benefits program. We covered about 820,000 public sector lives. So your teachers, public sector workers, professors, and our uniformed professionals. And now, as I work around the country with leaders like 32BJ, the bricklayers, the mass laborers, what we're seeing is employers have woken up to prices that they see as completely unjustifiable. In looking at prices and hospital prices in particular across markets, like Cynthia said, when you're seeing that you're paying really good money for access to a network, right? And that network price is $2,000 more than if I had just paid cash, something's wrong. Something's broken. I mean, I had just share a quick anecdote that demonstrates that. I went to an orthopedic urgent care. They couldn't find my insurance because I'm not sure why. I said, I'll just cash pay. And after some cajoling, I got them to let me do that. When they reprocessed my claim under the state health benefits program a month later, I paid cash, $300. When they reprocessed my claim, I got an explanation of benefits in the mail for $2,100. The taxpayers of New Jersey and myself paid a premium to get access to a network that overpaid that bill by over $1,000. Something's wrong and something's broken. But employers are waking up to that, and they're demanding information. They're not only demanding that hospitals post their prices and that insurance companies are more transparent, they want access to their data. And this is where we're coming up against a really hard brick wall. 32BJ is fairly revolutionary in that regard. Employers are saying, hey, Anthem, hey, Cigna, hey, United Healthcare, I want to see what I'm spending. You know, the state of New Jersey, we were cutting a check for $25 million a day to Blue Cross Blue Shield for our health benefits, and we weren't seeing what we were paying for. To use the credit card analogy, we were giving them a credit card. They were racking up, you know, paying the $2,100 to the urgent care and presenting us with a bill every day and preventing us from seeing what we were paying for. And there's good reason for that. You know, when we talk about, you know, I think it's closer to a third or more of administrative waste, that's what we're finding. And that's what these employers are finding. And they're taking their insurance carriers to court. The unions are leading the way on this, as Cora mentioned. We have a huge case in Connecticut with bricklayers, sheet metal workers, a whole class of unions. We had the Massachusetts laborers file a suit in Massachusetts, and we have other employers following suit to demand information and accountability. And it's huge, it's important. 160 million Americans get their health coverage from their employer. So it is a huge issue. And I just want to, I think it's 54% of folks that are scared to go seek care. It's important to know that most of them have insurance. We're talking about underinsurance, right? When you have a high deductible health plan or a consumer-driven plan that, you're going to have to spend $4,000 out of pocket before you even get your first dollar of coverage, you don't go to the doctor. You don't get that MRI. You don't get that lump checked out, and that's wrong.
So, Cora, you've been able to design a plan. Maybe you can talk a little bit about your plan design that ended up rewarding your employees and preventing those types of expenditures.
Happy to. So, I think one of the things to think about is we've been really revolutionary. We've had our claims data for now almost 20 years. Fought really, really hard to get it. But what I know now is way more than I knew 5 years ago or 15 years ago. And it's actually, I'm going to know more in a year. And that's in part because we've had to fight, claw that information tooth and nail, data feed by data feed, to get the receipt for what we've paid for. But in doing so, for the last few years, we've been looking at all of the claims data, reverse engineering, as Cynthia put it, and we were able to see that we were paying wildly different prices for the same exact thing. At the most highest priced hospital in New York City is New York Presbyterian, and we were paying $10,000 for a colonoscopy there. Another high quality academic medical center, Mount Sinai, I was paying $4,000 for a colonoscopy. There's no way a colonoscopy is worth 2.5 times more at a hospital literally across the park. And so as we started to do this, we tiered our networks. We did that in 2018. And then finally in 2022, we ended up removing New York Presbyterian Hospital from our network. And that wasn't an easy choice because it impacted 25,000 of our members. But let me be clear, we created a win-win situation and our members understood. The fund partnered with the union, and they went to the streets, and through public action and public conversation, most of our union members can talk to you about why we made these benefit decisions. And it's to have the premium-free health care, to have the ability to go to certain hospitals to have a baby for no copay. And so any of you who have had kids in this room, you probably paid more than $0 to have your babies. And so we did this, but the thing I always like to say is that you can't just make changes that limit access without creating win-win solutions. So as Cynthia mentioned, the fund has been able to save $35 million a year, and now we're on year 3. This is how she gets to 100, and that's a big number. It always makes me nervous. But during the most recent contract negotiations between the employers and the union, about 10 years ago, they realized if we fought together against healthcare prices, and hospital prices in particular, we wouldn't have to fight over it at the bargaining table. I can see the union organizers nodding in the room. And so they've been able to create win-win solutions. So the union was able to give the largest wage increase in contract history, a $3,000 bonus, and a pension increase.
Oh, that's great.
Meanwhile, on the employer side, because again, you have to make sure this is win-win, and I, as a fund, I report to both the employers and the union, so they both have to stay happy with me. The employers got a 2-month premium holiday, which essentially netted their premium increases to 0, and the premiums will not go up more than 3% for 2024, 25, 26, and 27. So I don't know, most of you in the audience. I don't think most folks will know what their premiums look like in 2027, but we do. But that also means it's on us as the health fund to know how much income is coming in for the next 4 years, that it will be our responsibility to look at this data, have access to more and more data, to be able to see, okay, if this is what I'm paying, what is the cash price? What is other plans within the same insurance carrier paying? What could I get if I had other insurance carriers? And that is why it's so important to have the transparency, because you can't fix what you can't see.
That's exactly right. And look, a lot in Texas, and the states are actually getting on the bandwagon. And we didn't even talk about that, but in Texas, now you're protected. If that cash price is lower than your insured rate, they have to count it and reimburse you in the plan and also count it toward a deductible. And so, I just know of one patient that had an ACL brace after an ACL repair and said, I want to pay cash for that. Don't charge me. I'm not going to go down the hall of the brace shop. What was the price for the plan and for him with the brace shop? $1,500. He and the doctor went online and looked up on Amazon what the same exact model number was for cash. $150. So think if you're a family and you've got 5 athletic kids and how many ACL repairs you're going to end up doing or have braces and all of these things are so impactful to what that means. And Chris, I'd like to show a slide that is pretty amazing.
Yeah.
So Chris is a lawyer, and as she mentioned, there are lawsuits now. Kraft Heinz just sued Aetna because they started to get frustrated that in their audit they only got a handful of billing and claims data. The plan refused to give them all. And when they looked at them, they found they were being way overcharged. They sued Aetna for $1.2 billion. Aramark, hundreds of thousands of food worker employees. I know we've got a food worker here. Hundreds of thousands. They just sued their health insurance carrier for over $1 billion. Ford Motors sued Blue Cross for $1 billion. There's a big whistleblower suit in Missouri right now for all the commercial plans being charged by Blue Cross for an administrative fee to give back to the hospitals their tax amount. And that was put into the federal government. Department of Labor just sued Blue Cross in Missouri. So, Chris, tell us about, from the lawsuits, this slide just came out, that top line. This is a claim at the very top. And Chris can tell us what's happening here and the great reveal from the lawsuits that we're just starting to see in the public information.
Yeah, so pardon me, but I get really excited when I look at both data and lawsuit stuff. So what you see here at the top, as Cynthia said, this is just a claim file, and most employers aren't getting this today. This was just unsealed in a lawsuit. So you have on the far left the charged amount. This is what the provider says. This is the sticker price.
And Chris, this is like an inpatient
anorexic
or
a substance use disorder, or it's some inpatient behavioral health claim, a very long-term claim, so it's a very large claim. But these types of shenanigans largely happen. They happen a lot in the behavioral health space because a lot of times carriers don't want to pay for behavioral health. So we have a charged amount, and then we have an allowed amount. That's the most that the hospital or provider could ever get paid. And then we have the paid amount. This is what the provider actually received, $875,000. Between the charged amount and the sum billed, they were able to inflate the total bill to a much larger number. And when I say they, I'm talking about Cigna, in order to get to $11 million, because the savings fee, in this case, is from MultiPlan, and I know Senator Sanders is very familiar with MultiPlan. They're going to base their savings off of the delta between the sum billed and the paid amount. So if you see here, Cigna keeps $2.5 million. The provider only receives the provider receives $875,000, and this little-known vendor that most employers haven't even heard about because it's not disclosed to them when they pay their claims, MultiPlan walks away with $677,000. The employer is presented with a claim and a demand for payment in the amount of $4 million. And they're not told what's happening in the red and orange here. Now, this kind of claim happens in all different amounts across all different plans every day, and employers are losing a ton of money and they don't know it. But I think the most important visual here is the red. That's not healthcare. That's fact. That's, in Mr. Sanders' words, the religion of greed. That's, if I can get more, I'm going to get more. I'm going to inflate my bill, and I'm going to claim $2.5 million of that.
And to the employer, isn't it that, Cora, that the insurance carrier like Cigna says, we're going to share the savings with you. We'll just take a percentage, and it's either 30 to 50% of what we save off of that funny number that's as high as it can possibly be, because the bigger the top line is, the more money the insurance carriers make.
And likely all that the employer would see is either that they paid $4 million, or if they ask the carrier, well, you know, that's a rather large claim, what they're going to hear back is, well, it's not 11 million. We saved you a boatload of money. And that is the response that they will give. And that is, you know, representative of the waste and the bloat in healthcare. I mean, we have $1.4 trillion of that total $4.6 trillion in spend. Almost $1.4 trillion
a year
for the 7 largest carriers. 7.
And if you think of that, and thank you, Chris, I mean, this is the first time, because this lawsuit and the data just got into the public domain, this is the first place and the first time this has been revealed. And it's shocking that we would see Cigna pay over 3 times for not giving health care, just being a middle player. And so when people in those focus groups that, you know, Kevin, we've done with the patients say, thank goodness I have health insurance. You know, think about the big business here, right? No. We need to start saying, thank goodness I have access to prices. Thank goodness Senator Sanders has been leading the way, too, to say in legislation proposed, we need access to actual prices from the hospitals, the insurers, and we need to see every single charge of those middle players. And on top of it, this big movement is to get access to the, what do the employers and unions need? Access to what's in Section 7 of that bill is?
Access to claims data. I always say it's like, you wouldn't go to a restaurant or go shopping and not ask for your receipt. But every day you go to healthcare and employers are not getting the receipts. And I always think it's really important because we talk about co-pays and co-insurance and high deductible health plans, and that is so important because it is stopping members, you know, individuals from getting care. But that rest of that bill that people don't see, that's every employer in this room is paying for that. And so you need to know what you're paying for so we can stop overpaying for everything.
And I think, you know, we talk about the numbers and that claim is shocking, and I could show you 20 more from that lawsuit. But we have to remember that behind that claim is a claimant, otherwise known as a patient, and a person. Mm-hmm. And that individual will get saddled, and their family will get saddled with a bill that is some percentage of that massive number. And that's somebody that says, okay, I'm going to go get help. But how many people who have substance use disorder, who suffer from alcoholism, who have an eating disorder, are suicidal, they say, you know what, I don't want to be a burden to my family. I don't want my parents to have to declare personal bankruptcy. I am not going to seek help. And we lose people as a result of that.
Kevin, anything you want to also add here?
It's an example that reminds me of a really great quote said in one of the State of the Unions by President Biden. He said, capitalism without competition is not capitalism, it's exploitation, right? And here's an economic fact. Without prices, you cannot have competition. Therefore, capitalism without prices is exploitation, and that's exactly what happens.
I think we're going to see, like we see it in LASIK surgery, or you see it in plastic surgery, you see it in any place where there's a cash market, is the prices have come way down. And they're really affordable. Even cataract surgery, we're seeing that happening as well. And the reality, too, is what is the percentage compared to Medicare? And I was just in another meeting where the claims were looked at and compared to Medicare prices. And sometimes employers have been charged for labs and imaging 600% more, 800% more, and an erroneous claim at 4,000% more than Medicare. And the only way you can refuse to be overcharged is to know what you're paying. And believe it or not, the big business of insurance carriers has made these employers handcuffed and unions handcuffed by making them sign contracts of gag orders, which is against the law now. And also that they couldn't reveal prices to their members. And the second thing is anti-audit provisions. And big accounting doesn't audit our health plans when Delta Airlines might spend over $1 billion. Why is it they don't audit the health plan? Because they choose not to. Because they consult to 20% of our gross domestic product being spent in healthcare. So if we want to compete as a country, I believe very firmly we can bring it down and get that $1 million back into all of our lives and our pockets and our wages. And it's going to take all of us to be democracy every day. And demand to know prices. Don't pay the bill till you get the prices. And if you can find a lower price, work with your employers. At that, I just want to say, anybody else have a final comment?
I would just like to say a bill passed in the House in December for price transparency, and it was a really good bill. The problem is, within that bill, there was a loophole that allowed, instead of real prices, estimates, right? And as we say at Power to the Patients, estimates are bullshit, because there's no correlation between the estimate you get and the end charge, and there's no accountability for the hospital that gave you a low estimate, correct? There's a bill now in the Senate, thank you, Senator Sanders, and bipartisan Senator Braun out of Indiana, and this is the bill that we are 1,000,000% behind. The last thing I'll say...
Because it's actual prices.
Actual
and
prices.
Actual access to the billing and claims data.
That's right. It is no doubt tough being a politician. I think it's much tougher being a humanitarian, especially in 2024. But being a humanitarian that's also a politician feels like it would be impossible. And so I want to thank Senator Sanders and his family and everybody here that supports his movement for human beings in this country. And thank you for being here. It's been a real privilege for me.
Are they going to play it?
Do we have a video with volume?
They disappeared.
Nobody's complaining. You know, lip reader.
So thank you very much, and we look forward to working with you in the future. So now we're going to break for lunch. Thanks.